I'm Patrick Brady, and I'm Senior Vice President of Sales and Marketing at Tryon Direct, and we want to welcome you to the panel discussion, an inside look at why 2020 is the year of primary care. And we're excited to bring you what we believe is a diverse perspective, and what we hope you take away are some things going on behind the scenes that could help you in your jobs and what you do. Now, like you, I go to a fair number of these events, and what I don't want to do is I don't want to have you leave here today and just take another data point on what's broken. This is really a call to action for you to empower you to take back some control, because all too often these events lead people like us to leave and feel hopeless and helpless, and that is not the intent today. So this is a look today at what's happening in healthcare, and if you see the pie chart here, you'll see that healthcare spending is a little over $10,000 per American, and in Charlotte, that number is about 18% higher. That may or may not surprise you. Primary care in the pie is 5% of the total. That's where we're going to hone in on today. That is part of the problem that you're going to hear us go deep into. Change in cost. So there's two components that go into healthcare spend. One is the unit price, and the other is number of units. Would it surprise you to know that utilization has been flat over the last 5 years? Flat. What does that mean? That means the price per unit has been what's driven trend. And you see on those two lines, the top one, of course, is pharmacy, and we'll dig a little bit into pharmacy because it's on everybody's mind. But look at outpatient. Outpatient is the yellow line, the second highest on that chart. Okay? So you start to see a little bit about what has gotten skewed in terms of pricing. It's not utilization, it's cost. I want to share with you a couple other slides just to tee up what you may or may not know. So right now, you as employers are paying 204% of Medicare for inpatient and 293% for outpatient. That is now a point of misaligned incentives. And unfortunately, you as employers pay for that. We have gotten things turned upside down in this country. Now, some of this won't surprise you. We all know healthcare is too high. 51% in this Health Pocket survey have avoided care due to the cost of paying for it. 4 in 10 have been unable to pay a medical bill at some point, and 30% have medical debt. This is not just a low-wage earner problem. This affects more of our population than we often think about when we're designing healthcare programs. The slide that I've got up now, it is no coincidence that you see referrals have increased over 90% in the last 10 years. That outpatient yellow line that you saw goes hand in hand with this. So what is the problem? The problem is not enough time and an inefficient delivery system where the primary has to push stuff out. What is direct primary care? So we're about to shift gears and take you out of the insurance world and into direct primary care. What is it? Okay, everybody knows today what you experience in healthcare, right? You go in for an office visit, you have to make an appointment. How far in advance do you have to make the appointment? A week, 2 weeks, 10 days, whatever it might be. So you make the appointment. You go for the appointment, and what happens? You end up sitting in the waiting room, you check in, you fill out paperwork, you go back. What is the next thing you experience? You get a 7 to 10 minute visit. 7 to 10 minutes. Dale and Jenny would tell you, if you're coming in for 7 to 10 minutes, guess what? they're probably going to be able to handle 2 of the things you came in for. If you've got 5, they can handle 2. The rest of them get referred out. It's just the sheer volume and numbers and time that it takes in primary care today. So what does that mean? That means no one is really satisfied with the way care delivery exists today. So what is Tryon Direct? Tryon Direct takes that model and flips it to where Jenny, as a practitioner, has more time to spend with the patient. It's no longer 7 to 10 minutes. It's 15 minutes, 30 minutes, 45, whatever it takes with that patient. Not only that, it gets better. You can get a same day, next day appointment. You don't have to wait. You get after hours care. You get portal access. You can email your physician. So you start to get that picture of what it means to have a connection to your physician and be able to access them at any point. That is the beginning of changing how care is delivered. What's the result of that? Your employees are satisfied. The quality improves. The cost goes down. So in the traditional model today, you see a nurse who brings you in, probably checks some vitals, and then they have you in a waiting room in one of the treatment rooms, and then you have your short visit with your doctor, right? So I call that 1.5 touches. You really didn't do a whole lot with the nurse. If you had to call back, the nurse would probably be the one to return your phone call, and I call that 1.5 touches. Direct primary care has 4 touches. Now think about that for a minute. Jenny is going to spend more time with you as the primary care physician. Her nurse is going to be involved with her, and we have the healthcare guide. So what's the result of that? The result of that is efficient referral. It's not a technology, let me give you a tool, be a good shopper, good luck to you, see you later. It's Jody navigating with that person. They have her phone number, they call her, she sits right next to me, so I know she talks to the patients. And let's flip it over to Richard. So Richard, you work with Jody, your company, your third-party administrator. What's your view on that same scenario?
She's great. But to give you the example that Jody and I went through November, I believe, within our normal business, we have a product service called bundled surgical services. So for all of our other business, if you go to a same-day surgery instead of the hospital, we're getting really deep discounts for that, and we'll waive the deductible for the employee, and that's within the health plan. So when we wrote our first case with Tryon Direct, Jody and Kendall came over to the office, and we went through the benefit plan design of this particular employer. So we were explaining the bundled surgery to them, our second opinion, and other stuff that we do. So as she said, they do deep dive into what the benefits are of that particular employer and employee. So we get this call, we get a pre-cert from our normal nurses and saying that we see this guy with this particular company has to have a hernia surgery. So we call Jody up and say, Jody, hey, we can do the same thing if you can help us get him to a same-day surgery. We've checked with a stop-loss carrier, we can waive the deductible and get a deeper discount. Let me step back. Our nurses are calling the employee after the doctor has done the pre-cert. Hey, your doc wants you to have this surgery at X hospital, and your benefits are $3,000 deductible, whatever you're out of pocket, that's what you're going to have to pay. We have a same-day surgery that's across the street. If you have it there, you have no deductible, no out of pocket, and it's paid for at 100%. Costs you nothing to have that surgery. So we took those same benefits and we called Jody and said, Jody, hey, what can we do? When we do it for the other business, it's about a 50% hit and miss. The employee goes, I'm not sure about changing what my doctor says. I'll pay the $5,000 or $6,000 bucks. Sometimes say, hell, shoot, yeah, I don't want to pay that amount of money. So they do change. So it's about a 50% hit. My point being is when it comes from the doctor's office that we're going to schedule your service at a same-day surgery center, the employee is rolling over and it's going to cost them nothing. So what it really gets down to is what we said in the past. This, from our standpoint as a payer, and should be from the employer, it is a true partnership in the healthcare. It is a true care team effect.
So let me ask Steve a question, and then we're gonna move into a little different area and go deeper so you start to hear more. Steve Adams is with us from Hickory Grove, and Steve's looked at our healthcare space for a long time, and he's been looking for a solution. I want you to hear from him what solution he has been seeking and see if you can relate to it.
I think the biggest issue for us is, like Patrick said, for 30 plus years I've been watching this, both from the healthcare side. I ran a business office for a large hospital in Alabama. And then now as an employer trying to find funds for my employees. The reality is, every time a renewal, I get a big knot in my stomach because I know that the group's coming with a huge number. And how in the world am I going to be able to afford this? Well, they've done everything they can, but how am I going to be able to afford this? And there's only so much as a nonprofit that I can do. I can't go out and sell more widgets. I've got to figure out how to provide this without passing everything on to my employees. And it's just the untenable task every year is how we're going to do this. We talk with our employees about managing costs, and I appreciate what doing with Guide. That's one of the things when Mark and McGriff brought Triumph to us. Really excited me in talking with Dr. Womack when we came and visited Triumph is the fact that I've got someone at Triumph helping navigate the cost for my employees and not just take, okay, this is, you've got to go have this done, go wherever you want. And, back in the old days when they threw a card on the table and it was $25, they didn't think anything about what the backside was going to be. I think the other thing for us that's really exciting as an employer is, yes, I'm interested in managing costs. I've got to manage costs. I've got to pass that on to my employees. But if we can build relationships with our primary care doctors and they can help manage the care of my employees, now I have healthier, more stable, happier employees because they've not only saved money in their pocketbook, but they're also healthier because I've got someone looking out for them holistically and not just one aspect. The specialist does this, then they're not communicating with, yes, like Dr. Womack said, I might have back pain, but, maybe my primary care doctor can help with that. And he or she is looking at the entire package and not just one thing over the other.
Why are we doing this? Why do something different? Why do it now? Why do it in Charlotte? So I want to start and tell you a little bit of my background. I spent 27 years in health insurance. I worked in sales, I led sales, I was at Blue Cross, and I was at Cigna. I have seen in that time what has not worked, and I have seen what's coming. And I'll give you a couple examples. 10 years ago, I worked on products to deliver to you as employers that would have tiered providers, tiered physician practices and hospitals. 10 years ago, we couldn't sell it in the market. Why? The noise of having your employees have to make those decisions with imperfect tools and the savings. The savings was no more than 10%. 10% for all that noise. And so employers said, no thanks, not going there, business is okay, we're going to stick with what we're doing. Well, fast forward, it's 10 years later, right? We're still in the same trend of 5, 6, 7%. Now, no carrier has sat still in those 10 years. They are both great companies, and there's others. There's other carriers out there. So, value-based care, right? It's this nebulous term. We all talk about it, and you'll hear it from us today. But what is it? Value-based care is the best a carrier can do for you. And what it means is it's a financial mechanism to try and help you, employers, to manage costs. Guess what it doesn't do? It doesn't change care delivery. And that's why carriers can't impact what Jenny's talking about in the physician-patient relationship. That's the only way you're going to be able to improve quality, lower cost. And I would say to you, there's a second way you're going to do it, and it's by having that relationship connected to you in the way that Jody talked about, and Richard and Steve. So value-based care, the best a carrier can do for you, any carrier, is 2%. Go ask your carrier how much they can impact medical trend. 2. Let's flip that. So in Tryon Direct, the savings potential that we see and that is in the market, and Dale will tell you and Jenny will tell you, Southeast is really the last place where you're seeing this unfold, right? So it's new here, it's not new across the country. The savings potential for doing what we're talking about today is 15 to 25%. And we're going to tell you how and why. So, landscape of what's happened in the past, what you're going to get elsewhere, and what direct primary care can deliver.
You know, this group was started back in the 1930s on Tryon Street. Here goes Tryon Medical Partners, which, by the way, is trademark, patented, and so forth, so it can go anywhere. But in 1993, the insurance companies were putting lots of pressure on the physician groups, decreasing their reimbursement. Okay, so the insurance companies, they have to make money, right? I mean, they're in the business of making money. They're not in the business of providing care. They're in the business of making money. And one of the ways they can do that is they can start driving down reimbursement. Well, the physicians who are not great business people and don't go to any business schools come out and they say, well, now we're in trouble. I mean, they even threatened to build a new office right across the street from us on Randolph Road where we work. So we seek refuge with hospitals because they're going to start competing with us, you know, trying to build office space and so forth. And we have no other way to get better reimbursement rates than to go with the hospital systems. And in the very early 90s, there was a huge move, okay, across all of Charlotte and Mecklenburg County, who was going to be first to go to which group and which hospital and so forth, and Presbyterian and then Atrium and so forth. It actually created a chasm in the culture of healthcare within Charlotte, where we were all collegial, suddenly we were in camps. Okay, that's first of all not healthy. Secondly, everything was working very well for a long period of time, maybe 10, 15 years. We were the major growth group for all of Atrium. We grew 11 total offices. We started the inpatient service. They took it from us because they failed 3 times trying to do it themselves. We already had ours, and they just took ours from us. They took, we actually created all their call system. We were their beta site for all of the things that they did within the county. and even starting into South Carolina, every initiative they brought out, they came through us first. We were very proactive. We also somewhat ran our own business for the most part, and they oversaw and all this type of thing. And then things changed about 5 to 7 years ago, probably 7 years ago. And then this thing called care model redesign started. And when you heard what Gaston said about how insurance companies, and especially Medicare, was going to have shared savings, well, where does this shared savings come out of? It comes out of hospital systems, because better care is decreased emergency room visits, hospitalizations, things of that nature, right? Where they pass that on to. No CEO at any hospital goes to the board and says, hey, we only lost 5% this year. Isn't that great? Okay, that's not going to work. All right? So they've got to increase their revenue continually, right? Remember, they're a healthcare business, first and foremost. They provide healthcare, but they're a business first and foremost. And then what happens is, when they're taking losses on bounce back readmissions to hospitals for congestive heart failure, COPD, these things, and then their shared savings on top, and their revenue starts to decrease, they've got to cut their expenses. They cut their expenses where? On the administrative side or on the providing side? Always on the providing side, right? The administrative costs have gone up 3,200% in the last 10 to 15 years in healthcare. 3,200%. So the first thing they did was they took the nurses away. Okay? Now, when we're in the office and we're behind the door seeing a patient, that makes it pretty hard to not have somebody who can make decisions on the outside. Because when we're in the room for 15 to 30 minutes or whatever it is, we've got calls coming in, everything like that, and all our decision makers are being taken away from us who know the patients. And we've got a lesser level of care available. So we didn't like that. And then they decreased our salaries more. And that's not easy either. But in order to make all of those things up, what did they want us to do? Push volume. 15 patients a day, 20 patients a day, 25 patients a day, more. What does more volume do? Gives you less time with the patient. 15-minute office visit. 15-minute office visit, at least half of it is with the electronic medical record. Okay? You got 7.5 minutes, don't have time. Can't handle all the things that Jenny needs to be able to handle, that I need to be able to handle. I used to be an internist with the group, then went and did cardiology, came back. So I've seen both sides of this, from both sides of medicine. And when then that happens, patients dissatisfied, we're dissatisfied. We went to 10 years of medical school to help people, not to run them through a mill. Okay? Wasn't about running through a mill, spit them out on the other side and see what comes out. And when I can't see the patient long enough, it's more fragmentation, more referrals that are unnecessary. 30% or more of healthcare is wasted, about $965 billion per year, just in the United States. So now we've got this situation where nobody's satisfied, you're paying more, patient isn't satisfied, we're not satisfied. So, I mean, somebody's got to run the gauntlet. You got patients and you got doctors, and they're separated by employers and healthcare systems and brokers and insurance companies. And the strength in healthcare and the most important relationship is the doctor-patient relationship. And unfortunately, and I'll apologize now, I think the physicians have abdicated their responsibility in healthcare. You can't change it. We can. But when an internist comes out and primary care comes out, they have $250,000 worth of debt on top of their head. And now a single internist can't make that much of a difference. But I can tell you what, 88 doctors sure as heck can. And that's what we did. So I went around the country and I found about all the information. So I call it knowledge, numbers, and resolve. We gathered the knowledge, taught everybody about it, had about 65 individual meetings with physicians before we ever went to our board and said, this is what we're going to do and hope you plan on coming with us. And so then we got everybody together and we had 88 doctors out of about 100. This has never been done in the entire United States. Never. And we had to sue Atrium to be able to get out. And we were successful. The most important relationship that allows an employer to have the strength is for the physician and the patient to bind together, and the doctors have got to put it on the line. Financially, professionally, ethically, morally, in every way. You can't do that. We have to do that. That's what's been missing. Once we do that, we now have a stable situation. 113,000 patients were sent letters by Atrium and Tryon Medical Partners of the patients we were seeing. We now have 125,000 patients already registered. 16% of the entire county. We have proven that patients follow their physicians, not hospital administrators. And now with that strong partnership, we can partner with you as an entity because we have the scope, the compass of all of the county. We have all the primary care doctors, 65 or more now. We have the vertical integration and that they'll talk about with all the subspecialists. And we're going to bring those subspecialists into Tryon Medical Partners because now they're incented to the same way we are, and now we're aligned with you. The two closest groups to the patient are the physicians and the employers.
Transparency is one of the key themes that we hear when we talk to employers. I don't get data, I don't understand data. I feel like my employees, our patients, don't really have information that they need. Kyle, being a researcher, working with Tryon Direct, has data. The whole premise of our model is to give you transparency and insight into what's going on within Tryon Direct. So Kyle, if you don't mind, just stand and share with everyone as you walk out the door this slide. Tell them what's in this slide and why it's important to them.
So this is an outcome slide. So I'm going to talk a little bit about the processes of how we get here. So this is the outcomes being total downstream savings. As we talked about earlier, if the physician's able to get more time with their patients, they get more access to their patients, they get to spend more time on preventative medicine, leading to healthier populations. Healthier populations lead to lower emergency room visits, lower urgent care visits, lower specialist utilization, less surgery. That in turn leads to cost savings. And it also leads to less prescription medications going out the door. It leads to cheaper prescriptions going out the door. So if we look at this data, the purple bars denote direct primary care clinics patients, and the blue bars denote non-DPC patients. This isn't the same employer groups. If you guys have any questions on the studies, please feel free to reach out to me and I can give you, how we conduct it and all that. But what we're seeing here is $200 less per member per month in drug costs, which is a very significant savings. And then overall, we're seeing about $500 per member, up to $2,000 per member per year in savings. So we've been studying this model across the country, and we can go on to the next slide. There's about 1,200 of these clinics now across the country. We're seeing this number double year over year. So Charlotte is one of the last metro areas in the nation to actually have this model come and take hold. It's not a new model to the rest of the country. We've been seeing some legislation push this out. So it started with Obamacare in 2009. We've seen Donald Trump press a couple of executive orders helping push this forward. The Centers for Medicare and Medicaid Services They've been launching pilot programs across the country, pushing this forward. And Medicare has also released a direct contracting value-based payment arrangement model, which will also help push Medicare patients into this model. So it's not new to the country, it's not new to Charlotte, or it's not new to all that. And the way that this model started spreading was actually doctor-led physicians. This is the way that they wanted to practice. Employers started catching on that this is a way to help my population be healthier and also save us money. So we've been seeing a lot of movement both wise and all that. And as a public health research, it's common sense, better access. Penny of cure equals a pound of penny of prevention equals a pound of cure. So it's just common sense that more we can keep our patients healthy, the less we spend out.
All right, I'll start us off. My answer to that is I think of it more like the Kaiser model. Kaiser model is wildly popular in certain geographies. Why? It's a great experience. It's a vertical integration. People have found it to be wildly convenient as opposed to healthcare outside of the Kaiser model. Here's why it's not an HMO. HMOs did one thing. They squeezed physicians, and I know that because I was on the health insurance side of it. We squeezed physicians to do more and paid less. And oh, by the way, if you referred out, you got paid even less. That is the world of HMOs from the insurance side of it. Anybody want to add anything to that?
Squeezing the doctor for as little as they paid him on the PEPM rate, and again, you get back to they don't have enough time to diagnose and take care of those patients. Yeah,
Yeah, good
so
question.
it's totally different. I mean, it's a membership fee to have unlimited access to your primary care doctor and everything that they do inside that office. And again, the one thing that attracted us with Tron Direct was the vertical integration of Dr. Womack could send something to Dr. Owen and he could look at it and send it back saying, this is what I think it is. If she had a question about it. And the other thing is, part of it is the clinical meetings that they have about each patient within the Tron Direct model is phenomenal because again, it gets back to that care team aspect.
I'm really glad you asked that because it's really so simple. We're hospital agnostic. We don't care. We don't care which hospital they go to. We have no reason to send to one versus the other or not to send to one or the other. We're going to send to the hospital system if their insurance requires a particular place. We'll direct them there if that's what they choose. But otherwise, we're going to pick the best person to do the work that needs to be done for the patient. Atrium said, I think this was a great comment, and I'm so happy they advertised for us. They said, well, out of 115,000 patients, well, gosh, they're already sending 70% of those people we're already seeing. I said, perfect, because that meant the other 30 didn't need to come to you to begin with, okay? They actually said it for us. There's the 30% of the waste. There's the 30% that didn't need to go there that we can send elsewhere, or we can take care of it ourselves. But if it's Paramount, or if we need to send them to Baptist for a particular thing, we have no blinders on towards any of those things. First of all, it's illegal for them not to be receptive. But yes, they've been receptive. Their emergency rooms. Remember, the physicians on the inside and on the outside all still get along very, very well. The coordination that we can provide to get them in is very easy. The problem is coming back out. It's the spend inside that just gets out of hand. practicing defensive medicine, CYA medicine, we call it. And then it's the on the other side, when they come out, coordinating the care on the outside, which has been done very poorly in the past. We can now make that very seamless.
Think of us as an add-on to insurance. We don't replace insurance. Everything within Tryon, as Richard said, is a per member per month fee. It covers unlimited primary care for all the patients. Anything outside of Tryon Direct gets billed to insurance. Now, why is that important? It's important because in that per member per month fee, you get a lot more than a traditional office visit at your primary care physician today. Let me tell you about that. So when you go in to see a Tryon Direct doctor for a visit, you get prevention, you get wellness services, you get disease management, you get case management, you get prescription management. You also get 8 categories of labs that go even beyond what the ACA requires for preventive care, which has to be paid at 100%, right? So for example, you get thyroid testing, that's all covered. So let's say now you do have to go outside of your primary care physician at Tryon, then the insurance picks up. It's very seamless. Employers, Steve would, well, let me kind of speak. Yeah.
One of the other benefits with Tryon Direct is, now those lab tests, those primary care visits are not hitting my experience rate. Because I'm paying that per member cost per month. Now that's where my experience is. I've controlled that cost. I don't have the uncontrolled expense of all the lab tests and other that are not covered. So there is savings because those visits to Tryon are not hitting my experience rate yet renewed.
Thank you.
It really gets back to what insurance is supposed to be, covering that catastrophic event. It's almost like, why are we insuring these low-level items where we can cover them at a per employee fee and then only pay insurance premiums for those items that we can't afford to pay? And that's what insurance is all about. You get this covered under the average price, $75 a month. But I've got unlimited access. I've got all my labs covered. I can spend 45 minutes with the doctor every day if I want it. I mean, I have one of those Sam Express car washes. It's $30 a month. I got unlimited car washes. I can go every day. I can go on the way to work, and I can go when I go home. I can go by the car wash. I got the same access to my primary care doctor. And it's not, don't get confused of the primary care doctor with only preventative care routine exams.
Yeah, good point.
It's everything that can be done in that office. Like they said, disease management, I don't, but diabetes, high cholesterol, whatever is my condition, they can probably handle 80% of what ails me or what ails your employees, and not as I said, or we've said, employees are not good navigators of healthcare. This is going to make them good navigators of healthcare because they're going to use the primary care doctor first, and
30%.
not self-refer to a cardiologist or orthopedic.
And tagging on to that, 30% of the referrals that I get in cardiology are completely unnecessary. Completely unnecessary. And it's because people like Jenny didn't have the time to take care of these things. Internal medicine is, the 5% of your population that's spending 50% of your dollars. Here's your expert. I mean, she's smart as a whip. She's gone to school for medical school training, 3 more years, and so forth. I mean, generally most people have 10 years of this going in, very dedicated to the people. And internal medicine is different than a lot of the other subspecialties. because they do only adult medicine for 3 straight years. Family practice only does it for 1 year. Peds, none. Your big cost is in adult medicine, especially in your very complex people. That's your quarterback. She's your quarterback. And when she's unleashed to do the things that she can do and not have to be seeing somebody every 15 minutes like this, now she can do what she's trained to do at the best of her licensure, when she wasn't allowed to do it before because she was having to run a mill. Okay? And now she can cut your spend because she doesn't need to send 30% of those people to see me for things that were completely unnecessary.
Well, I think that's where the model like a Triumph is so important, because now we can build relationships, as an employer and employee. I know that when I go to see my physician, I've built a long lasting relationship, not with all these different specialists and stuff. They're not talking to each other. If I've got one gatekeeper, now I've got a primary care physician that's looking at all of everything that's going on in my life, and not just one aspect or another. And that's what I'm talking about with the relationships. Now, if they can be long lasting, in this membership aspect, I think helps that. Now, my employees are going to, over the years, be seeing the same person, and they can watch the benchmarks with this employee going up. Is their weight going up? Are the other issues happening? So now, and I'm not a medical doctor by any means, I just see this on the outside, will this help my employees now not only save those dollars, but will they be healthier and happier and more productive employees because of it? I'll tell you our model, and we know that this is new. I mean, when I pitched this, I've been watching this for years, just because I'm just fascinated with all this. So I immediately bought it. When Mark brought it to me, I said, let's go. We got to do this. I was sold when I went and visited Triumph, met some of the physicians. I said, I'm in. We've got 225 employees. They weren't all in immediately. I get it. I mean, there's relationships they've got with other carriers. So we began a hybrid model where we supplement some of that. We subsidize that cost, and then we pass a portion of that cost on to the employees. Now, I'm hoping, my prayer is that over time, we'll be able to subsidize the entire amount because of the savings we're going to experience with that stuff not hitting our experience rate.
And that is called investing in primary care, which unfortunately the United States doesn't do. The other countries in the world have realized that to prevent the downstream spend, they had to invest on the front end in primary care, in health management, and so forth. That's what's been missing. And what he's talking about here, he's going to see that happens. His costs are going to go down, and he's going to be willing to supplement it himself because it's investment, and he's going to save money on the front end. That's hard to believe, that by paying some up front, you're going to save more on the back end, because that's not what we're used to. We're used to the opposite.
Richard?
The groups that we placed with Dry and Direct, we did full takeovers, if you will. So the employer's paying 100% of the membership fee. The plan design is your primary care doctor is one within these 9 locations. They're strategically located, so you pick whatever location you want to go to, and when you get there, you pick your doctor that you want to go to, because they've got 3 or 4 or 5, 6 primary care docs in each location. So it's a matter of, here it is, you get everything that you do in there is free. Doesn't cost you a dime. There's no copay. Nothing goes to the deductible. You don't have a lab that your office visit went for the $25 copay. The lab got charged to your deductible. Everything's paid at 100%. If you go outside of that, then yes, you have a higher copay, or it goes to the deductible if you had to go to the specialist or somewhere. But all primary care is covered at 100%, and everything done within that list is paid for at 100%. It is actually, I say free, but it is actually flying first class. When they get in there, those 4 touches that he talked about, if you've ever flown first class, you'll never go back to coach. Okay? It is, yeah.
Well, the difference is you can afford first class for trying.
That's
You
right.
can always afford to fly
That's right.
to America. There is
That's
a difference here.
That's right.
I would tack onto that though, because one of the really great things about this is that for the first time, physicians are aligned with you to cut the cost by putting their efforts on the front end and the spend on the front end to take care of people so there isn't a big downstream back end spend. Because what's going to happen? You're going to come and look me in the eye and say, you got to fix that. So I need to fix it on the front end rather than having you come to me on the back end. So Jenny, when she sends somebody to me, I'm going to be helping her not have to see me and go outside of the try and direct model. She's going to call me, what do you think about this EKG? I think you're fine. You don't need to send that patient to me. What do you think about these palpitations? Tell them to get off the caffeine. And if they don't get any better, send them to me down the line. I don't have to go. I'm not incentivized to spend your money. I'm incentivized to do the right thing for the patient first.
We do that. We collect it just to do payroll deduction. And let me say this, and I'm not a paid endorser. I didn't get paid to be here today or anything like that. So just because I believe in the
That's
model.
too bad.
I know.
You want to see my check?
But most of us old enough to remember the old brand filter commercials with the mechanic, you can pay me now or pay me later.
Right.
And that's basically what this is. And that's the whole point is I want to help my employees pay that cost now and prevent that catastrophic disease or illness, because not only do they save money, but they save their lives, they save their health, they're healthier, happier employees. So.
Hey, let me get tactical for a minute. We got one question. I think we got time for 2 more. We got one up here, one back there. But tactically, what we know is the same model doesn't work for everybody. Just like you heard from Steve and Richard, the different ways of kind of approaching it. We have a full population health model, and it is priced accordingly. What does that mean? It means that if all of your population participates in Try and Direct, you get volume pricing. It's lower. If you go, no, I'm not ready for that. I want to toe in the water. I want to figure out how many people would do this. We have pricing for that. You pay per person. That's in the program. So we've designed it to be flexible to meet your needs because of what you just asked, which is everybody's going to think about this differently in how they want to proceed.
Okay, why are they so late to the game? All right. I'll say it as fast as I can possibly say it. Fee-for-service is we're the last bastion of fee-for-service in the United States. Georgia and North Carolina are the 2 highest. Charlotte is the highest in the United States. Physician salaries were the highest in Charlotte than any other city in the nation relative to what they did. Okay, so the rest of the country's already gone through this. It's going to get painful in Charlotte because they've had 10 years to change. You're going to have 2. It's happening rapidly where value-based medicine is going to come in. Charlotte, North Carolina will be the center of the vortex in healthcare change in the United States. Bank on it. That's why Patrick Conway came from CMS to Blue Cross Blue Shield of North Carolina, because he knew he had the opportunity to make the change. He made a mistake. Now he can't make the change, but we can and we have. He always knew, because he's a physician, he always knew it had to be the doctors who had to make the run. Well, what we do for that, what we do for that is understand that we need to hire the physicians ahead of that. okay, instead of dropping 2,400 patients on a particular physician, the general range is somewhere between 1,600 to 1,800 labeled or registered patients for a particular physician. We already have plans right now because we're ready to start hiring now. Okay, and in our current offices, and mix and match on half days off and all this type of stuff. But also, there's other areas around the county, west of the Catawba River that you may have heard about, in Gaston County. Lots of opportunities to make this work for lots of different areas.